It's 8 o'clock. We'll get started. Good morning, everybody. Welcome to UH Epilepsy Grand Rounds Monday morning here in Cleveland. It is my great pleasure to be able to introduce our speaker today, Professor Ingmar Blümcke. Professor Blümcke is a full professor and director of the Department of Neuropathology at University Hospitals of Erlangen in Germany. Dr. Blümcke pursued his medical studies at Christian Albrecht University of Kiel in Germany. He did his postdoctoral training at the Institute of Histology at University of Freiburg in Switzerland. He completed a 3-year residency in the Department of Neuropathology, University of Bonn, Germany. Professor Blümcke has published more than 450 peer-reviewed articles, more than 30,000 citations, and an H-index of 95. He's a chair of the ILAE Commission on Diagnostic Methods and Neuropathology Task Force. He's also the chair of the European Epilepsy Brainbank and the German Neuropathology Reference Center for Epilepsy Surgery. He has won several awards, including the ILAE Ambassador of Epilepsy Award in 2015. Professor Blümcke's contributions to the field have significantly advanced our understanding of the pathology of epileptic brain lesions. He has been the lead author on landmark papers on ILAE consensus classification of focal cortical dysplasia and hippocampal sclerosis. Thank you so much, Dr. Blümcke, for being here with us.
Thank you, Neil. That is fantastic. Good morning, everybody. Thanks for joining. And let's have an interesting meeting this morning. So my duty is to convince you, so that's at least what I hope to do, convince you that a little bit of knowledge in histopathology and neuropathology is beneficial for your daily work as a clinician. And then we can probably have at the end a small discussion whether or not I was able to convince you about that. So neuropathology is your diagnostic helper. And that is something I would really try to reinstate that. I mean, all of you learned that in medical school when you took your classes in pathology. That's kind of the ground basis of all of medicine. And the principle is, of course, the same in neuropathology, where we have a specific diagnosis, and that is characterized by its specific cellular and now more or less also its molecular alteration. And we can microscopically recognize these specific cellular imprint that defines a disease at the microscope. We can identify that at the microscope. And the cellular signature points always to the underlying disease mechanism. And this, what I mean here is in a broader sense, like if it's a neoplasm, if it's a malformation, if it's inflammatory, if it's neurodegeneration, vascular, and so forth. So that is one very important part of our daily work to guide you towards the right mechanism of disease that you are able to target then with whatever therapeutic approach you're choosing, whether these are drugs, surgery, or any other interventional strategy. Okay, so and today I want to wrap that or pack that into kind of guiding principles that we have at hand, that we follow, and that I try to explain to you. And these are basically 3 guiding principles. I will start with the most important one, because it's true for all of medicine. Frequent is frequent and rare is rare. Just to remind you that you probably, when you see your patients, 80% of them is a well-known phenotype, right? You have everything at hand, and that is holds true roughly about all spectrum of all medicine. And as an extension to that guiding principle, it needs to be recognized that whoever frequently diagnoses a rare disease will frequently be wrong. And I want to go into that detail with referring to our large database of the European Epilepsy Brainbank that collected now more than 10,000 epilepsy brain tissue samples. That was published in 2017 on 9,523 patients from 36 European centers across 12 European nations. And we had a minimal data set consisting of the diagnosis, the neuropathology diagnosis, sex, site and location, age at onset, disease duration, year of surgery, and then roughly also the post-surgical outcome 12 months after surgery. And saying, frequent is frequent and rare is exactly what you can see here, having the entire spectrum of these 10,000 patients were classified only into 7 major categories. And the third most frequent ones almost comprise almost 80% of the entire cohort. So the first one was hippocampus sclerosis. Then you had these low-grade congenital brain tumors with early onset in childhood. And then you had malformations of cortical development as most frequent category, right? Category, not single diagnosis. Then no lesions and vascular malformations, glial scars comprising stroke and traumatic brain injury, and then encephalitis, including Rasmussen and limbic encephalitis and so forth. But even if you go into the top 10 single diagnoses, either in children, so until where surgery was done until the age of 18, or in adults where surgery has been performed at patients being 18 years and older, the top 10 diagnoses accounted for 90% in the adults and 80% in the children. And this is exactly what I think. So whenever you have a focal epilepsy in a patient, it's highly likely that the patient has one of these diagnoses rather than any rare disorder. Okay, so this is something that I would really like you to understand, that frequent is frequent and rare is rare, and whether it's hippocampus sclerosis, these ganglioglioma, no lesion, basically meaning MRI negative, then the FCD type 2s, cavernoma, DNET, and so forth in the adults, and then the same in children. With a different order, of course. Here in children, the most frequent disease entity are focal cortical dysplasia type 2, then followed by hippocampus sclerosis, and then ganglioglioma and DNET. And again, these 10 entities sum up to more than 80% of the entire cohort. That has not been published in that paper. However, what we know from several studies that came afterwards and were more systematically collected, where the data was more systematically collected, that you lose the probability to get your patient seizure free with the duration of the disease. So this is here in years, 10 years of drug-resistant epilepsy, 20 years, 30 years, 40 years. You see there are still many dots around, and that is your relative seizure freedom rate. I will come to that graph later. It's just another one that has not been published, was not accepted by the New England Journal. However, it's very important to understand that the most important predictors for your patients to become seizure-free is indeed the duration of the epilepsy. So the longer the duration lasts, the less likely you will have a seizure-free outcome. Then second most important, it's a type of the lesion. That is important to recognize. And thirdly, the localization. In other words, in particular, temporal lobe epilepsy do better after surgery than the rest of it, in particular occipital or parietal lobe. So, however, we extended that study in a second publication that was then published in Lancet Neurology in 2020, where we looked particularly to the post-surgical outcome. There were another 9,147 patients from that previous study were included, where we had a 1, 2, and 5-year follow-up. And also the knowledge whether or not the anti-seizure medication was withdrawn. And very similar to what we've shown before, it is here as a quintessence of the study 5 years after surgery, like 50% of our children were seizure and drug-free when they were suffering from a brain tumor, particularly this congenital tumors. They had a vascular malformation or hippocampus sclerosis, and then it goes down. So that is something that you really have to understand, that seizure and drug-free 5 years after surgery in a chronic disease that the WHO has rated as amongst the most severe chronic disorders that we have in all medicine. Okay, and of course in adults these numbers were fairly lower, and that is probably due to the lesser percentage of adults being off drugs, maybe because of the issues with the driving license or other things. However, so these numbers were lower, but still you see that epilepsy surgery has a high propensity to make your patient seizure-free and drug-free. So in other words, being cured from a very devastating chronic illness. And that is another graph showing basically similar results. Here again, the duration of epilepsy, and here the predicted probability of seizure freedom over all these 9,000 patients. And you see that there is a probability to lose the seizure freedom rate with ongoing or with longer lasting duration. And you can, a rule of thumb, say, you probably lose 1% of seizure freedom per year of active when your patients still have active epilepsy. And these findings are corroborated in many different studies now. So I think this is something you have to take into account, and that is basically coming from this very systematic review, including the histopathology data. So that brings us to the second guiding principle in neuropathology, and that is etiology matters, right? So we have to recognize the disease-defining structural pattern at the microscope or in the genetic coding as the basis of your disease classification. I think that is the core matter of histopathology, and you are less acquainted to that, and I hope I can convince you that this is something that you use almost on a daily basis. I mean, first, I would briefly introduce into how we deal with the tissue. This is all coming out of the surgical theater. Here, this is the University Hospital Neurosurgery department, and we have this intraoperative magnet for almost 20 years now installed. It has been a 0.5 Tesla, now it's a 1.5 Tesla. And that makes these surgeries very safe. We have very little comorbidity, and most neurosurgeons that are trained in epilepsy surgery conduct very safe surgeries, very little comorbidities. So you can really tell your patients that this is a very well-established procedure. And then this is an important picture for me, because it it shows you, or it shall show you, how we cooperate already in basically at the patient management conference, where neuropathologists should be included and involved. And then here, this is the surgical plan in one of a patient who previously received stereo EEG. You see here also the electrodes, and then this is the surgical plan where the resection should be performed. And then you see here that the surgeon has labeled the different axes, so that we know where is anterior and posterior, and dorsal and ventral. And that is important because that could guide our section plane. And afterwards, if you want to know something specifically relating to an MRI finding or an EEG finding or something of interest, it's only possible if we can connect to the anatomical landmarks. If this comes without these landmarks, it can be flipped around, and then we lose the exact orientation. And then you have these slabs, and then you can use them for fixation. Let's say this grayish and blackish ones, they will go into paraffin for histopathology, but still you would have adjacent ones that can be used for other research studies if you have IRBs approved and funding available. But that is very valuable because it's kind of living human brain tissue that deserves further research studies. And then, of course, we have to do our magic to bring these tissues into the microscopic preparation. That is, at the end, very thin. It's a very thin 4 micrometer thin paraffin section. So you need to fix it in formalin, and then bring these slabs into these paraffin blocks, and then you can cut them on a microtome and do the different stainings either by hand or by these fancy machines. And this is something that may explain to you, hopefully, how we consider or how we judge these cellular patterns. So these are 4 different patients, and we use here a special staining using antibodies. So the brownish color is when the antibody is bound to the specific epitope on this paraffin section, okay? And then this bound antibody gets developed by a color. Here's brown. And then we use a bluish background staining just to mark just to review the anatomical landmarks. For instance, here's the surface of the brain. Here you see the peel surface, subarachnoid space, and then you have layer 1 with very few neurons, and layer 2, layer 3, so the outer pyramidal cell layer, layer 4, 5, 6, and then the white matter. And this is a control patient taken from autopsy. So if you compare that kind of control situation where we consider a typical 6-layered homotopic neocortex and compare it with either of these different phenotypes, you may appreciate the difference right away just from this very same objective magnification. This is all the pictures were taken at exactly the same objective magnification. They were cut exactly the same thickness. They were stained exactly the same antibody and counterstain. So the difference here is just that you see here no equal distribution of neurons within the space, but rather like pearls on a string, aligned on a string, right? So that's what we call, our predominant microcolumnar orientation. And still the layering seems, a little bit visible still, at least layer 1, layer 2, maybe 3, 4 is maybe not so easy, but still it's there. And then you have the white matter. So here it is somehow the architecture is disturbed. It's not really that individual cells are different. So if you would take a small picture at a very high magnification from the control situation and compare that with this FCD here, would not show a big difference. So this is why we call it architectural only. So it is this kind of vertical abnormality that dominates the picture, and that is what we call here FCD type type 1A according to the ILAE classification scheme. Then we have FCD type 2. Here you see also that the architecture is not very the same compared to the control, but in addition you have very large cells. And with this antibody, you only see the neurons. You do not see the glial cells or any other cells like balloon cells or so. It's just the neurons, but these cells here are 10 times as big as in the FCD type 1 or the control. So this is why we call it cytoarchitectural. Okay, and then here you have a different disease pattern. Here you have in the subarachnoid space, you have this large vasculature anomaly. This is a Sturge-Weber syndrome, a meningoangiomatosis, and then the cortex beneath is very small. It's hypoplastic. It's missing certain layers, like here this layer 2-3 is missing. And that is, again, an architectural abnormality because the individual neurons are very much the same than here and here, but the architecture is missing. So this is how we recognize these patterns, and then we put that together into a classification, because we have seen that again and again, and it has been seen in different parts of the world, different labs reported that. So it's not that you see that only once. It resembles one and another, and if that resemblance is clear and fits with the description, we give it a specific disease name or diagnosis. So this is how we classify diseases in all of medicine, by the way. The same applies for liver, for kidney, for heart diseases. Of course, cancer is very much the same. And also here, the brain malformations. And that is this kind of classification. This is now an update that has been published 2022. The original classification was published in 2011. And there's where we have this type 1, type 2, type 3 that I just showed you with this cytoarchitectural abnormalities, with the architectural abnormalities, sorry. So abundant microcolumns, abnormal layering, and then vertical and horizontal abnormalities. Here in type 2, you have this addition of cytological abnormalities with the dysmorphic neurons, very large neurons, and the balloon cells. And then type 3, basically cytoarchitectural abnormalities that are closely associated with either hippocampus growths, a brain tumor, a vascular malformation, or any other lesion acquired during early life, because then it compromises the further development and maturation of the neocortex. And that is all based on the histopathology pattern recognition. So each of these subtypes, disease subtypes, have a clear definition of how they look under the microscope. And then more recently, we have included 2 more disease categories. This is mild malformation of cortical development that is defined by excessive heterotopic neurons. If you just review that you have here more of these heterotopic neurons, this is also a feature that we see quite often in epilepsies. It's if this is the only lesion that we see, that we call it MMCD, mild malformation cortical development, or then a more recent diagnosis that we defined in 2017, the MMCD with oligodendroglial hypoplasia in epilepsy, or MOGI. And then if none of these lesions can be recognized in your brain sample, then you should call it no specific FCD on histopathology, just to make sure that we are not intermingling with these specific disease entities. So if this is true, what I just said, that these common histopathology patterns can reliably define subtypes, then also AI-based algorithms should be able to classify FCD when we use fully digitalized histopathology slides. And that is the era of digital neuropathology that we're right about to start. And I will give you a very brief introduction to that. So here is a fully digitalized epilepsy surgery specimen, and then the computer extracts all these tiles, and each of these tile is then submitted to a classifier that was trained based on a deep learning algorithm, a ResNet algorithm, and then it gives you with a certain confidence that you choose the diagnosis. And that is the interesting part here, just that we were interested to understand what the algorithm is recognizing as an important structural lesion. And this has been, of course, published already. And here you see in yellow that is important. So here in this FCD type 1A, showed you before, these microcolumns. So this is what the computer recognized as is important structural feature. Then in the type 2A, so here are these dysmorphic neurons. So very, very large neurons. Again, this is in yellow what the computer recognizes. And here, this is an FCD type 2B with these balloon cells. And it's again the structure that the computer recognizes. So in other words, we trained an algorithm that somehow really recognized these features. And that is now a second paper that was just last week accepted in Epilepsy, and where we make a use case scenario with this AI-based classification scheme or classifier, testing the FCD type 1A, 2A, 2B, MOGE, and MMCD phenotypes. And you see that in these cases here, and this is just the tile number, the tiles recognized by the computer as being diagnostic, and the majority in these cases of FCD1A also show the lesion of the 1A. And the same with the FCD2A, the majority here recognize a 2A. There's only one case where it's not the case, that's a 2B. Of course, the dysmorphic neurons are basically the same than the 2A. It's just the balloon cells that are different, and the balloon cells are here not the majority. So still, you know, the reader has to review the tiles to make the diagnosis of a 2B here. But again, in MOGE, the vast majority of tiles were recognized as MOGE with these oligodendroglial hyperplasia, and here the heterotopic, excessive heterotopic neurons in the white matter. So I think that is the way forward to provide also a more objective measure of these different subtypes, and that is all showing you that the second principle, guiding principle, described that these patterns exist, that they are recognizable, and that they are almost the same across different patients. And here's an interesting other result of that study by my PhD student Jörg von Rahn. So this is an FCD type 2B, and you see here many of these balloon cells around the purplish FCD type 2A hyper or dysmorphic neurons. And then again, there is another entity at the border of this type 2, which was classified, or which was trained as an FCD1A, which is an architectural dysplasia in the vicinity of this type 2 lesion. And that is something that we have not really addressed in the current classification scheme, but that is of course now interesting to follow up if that is a principal pattern, that the lesions are basically a little bit bigger than visible on MRI. Let's say this part here in the white matter with the many balloon cells are the most visible part picked up by the MRI. Then the dysmorphic neurons in the gray matter may not be that much visible. So, however, and then this architectural dysplasia is also something not very well visible, but it defines a much larger lesion in total. And that may be important to recognize also when planning for surgical resection, to understand that that these lesions are bigger than they appear on the MRI. If you really look in detail, and now we have these objective possibilities to study, then you will understand that if you just resect the lesion without measuring the EEG abnormalities around, then you may create a surgical failure because the lesion is bigger than it appears on MRI. Of course, we have different other classification schemes, for instance, for the hippocampus sclerosis. And you see here 4 different subtypes. No HS here, again, this brownish color for neurons are stained in the hippocampus here in the CA region, CA1, 2, 3, 4, and then the dentate gyrus granule cells. This is fully packed with neurons, and that is an epilepsy case. However, this is classified as no HS because there is no segmental or any other neuronal cell loss, and that is very different to this type 1 that is severe, or the classic hippocampus sclerosis phenotype, where you have almost all neurons in CA4, 3, and 1 gone. There's a few resistant neurons in CA2, and then of course many more neurons in the subiculum, and the granule cell layer is also compromised. But that's a classic pattern that we see in the majority of cases, and that is also different from this atypical hippocampus sclerosis type 2, where there is predominantly only neuronal cell loss in CA1 compared to CA2, 3, 4, or the dentate gyrus. So this is different from that and different from that. And then we have a fourth pattern that we call ILAE type 3. It's also atypic, it's rare. So these 2 rare entities here probably account for 20% of all our hippocampus sclerosis only. And there is a predominant cell loss only in CA4 and not in CA3, CA2, or CA1. And that is, again, something that can be seen again and again. And we truly believe that this has some impact that is important to recognize. For instance, this is the very classic pattern where you have this initial precipitating injury at the early ages, like the first years of life. Then you have this latency period, and then the first seizures occur at age, let's say 9, 10, 11 years of age, and then they eventually grow into a spontaneous recurrent temporal lobe epilepsy. But these 2 atypical ones, they usually lack this latency. So they probably start right away, a little bit later the age, and then right away without this latency period, and so forth. So there are several, and I cannot go into all these details today, but that gives you an idea, and you can read that up, about how these disease classifications inform you. in decision making, or also when you work up the patient. It's not only that you need to know that after surgery when you read the report, but many of these patterns uh, co-register already with the MRI findings, and you can project that this might be a different pattern, and then you may understand certain variances that you see in your clinical history, or your response to drug treatment and so forth. And then, of course, the third classification scheme that is very much pathology driven is that of the WHO about all the brain tumors. Now we are running the 5th edition already, and there are many brain tumors that relate specifically to focal epilepsies, in particular the glioneuronal and neuronal tumors. And I just show you here are some of them. You know, that these are the more classic ones in black, and then the greenish and bluish and reddish, they came with each different edition. And it's an increasing, growing list, and I will not share all these details today, but that's also something we need to take into account, that these classification schemes may change over years if there is new information and more predictive and prognostic value that can be obtained from the histopathology report. And that obviously most of that goes back into the 19th century. And this is just one of our heroes, Rudolf Virchow, who was the chair of pathology at the Charité in Berlin. And well, I call him the founder of cellular pathology, and therefore of modern medicine, because it's exactly what he trained his students, that every disease that you really specifically call a disease and write it down should share its specific histopathology pattern. At that time, it was obviously like tuberculosis, very frequent, and they saw these specific granulomas. And then one of his friends, Robert Koch, identified even the bacteria. However, they didn't know at that time, but people like Virchow, they said, whenever I see this granuloma, it is tuberculosis. And then it came, very much later that they really identified the bacteria. And as you know, still, sometimes it's very difficult to identify the bacteria, but we all know if this is this specific granuloma, it is tuberculosis. And that is exactly how it works. And that is how in epilepsy surgery, we identify these malformations and inflammations when we see these lymphocytic infiltrates. This is all now helped with immunohistochemistry. Then neurodegeneration here. This is, for instance, neurofibrillary tangle in Alzheimer's. Here, this is a neoplasia. And here, this is a secondary degeneration. So this is like the foundation of modern medicine, these cellular pathology patterns that we can recognize. However, we are in the transition now from cellular to molecular pathology, and vice versa, from modern to personalized medicine. So in other words, what we do now is we take these samples and look into the genetic features, and then we see this malformation may be an mTORopathy, because the mTOR gene or other partners of the mTOR signaling pathway are compromised. And here we know that the neurofibrillary tangle that Alois Alzheimer described in the early 20th century based on his silver stain, now we know it's a hyperphosphorylated tau, and we call it a tauopathy. And here, this neoplasia is a ganglioglioma with a BRAF V600E mutation, point mutation, and that gives us the ability to use targeted therapies, specifically targeting these genes. And in the secondary generation, we usually do not see specific genetic lesions. And also with these inflammation, for instance, this is an anti-gut encephalitis. So now you draw the CSF and you go and you screen for these antibodies, autoantibodies, and you can make a much more precise diagnosis, and you have a different arsenal of therapeutic strategies at hand. And then you also understand whether this is an aggravating encephalitis that is more devastating with neuronal cell loss, or where the encephalitis may not be so harmful for necrotizing tissues. Okay, so that brings me to the third and last guiding principle that we have now. We are now in the process of integrating the histopathology with the molecular pathology, and some people call that point 2.0. And of course, that is all the avenue towards precision medicine, and you see that is already a major part of neuro-oncology today. In neuro-oncology, you are obliged to not only understand the histopathology diagnosis of that cancer, but also the molecular genotype of it, because it gives you much more insight into available drug treatment strategies, or chemotherapy, radiation therapy, protocols. And of course, we need the brain to do the DNA test. It's usually not available from just a blood draw, but you need to look into the affected brain tissue, because what we are dealing with here are somatic mutations. So post-zygotic somatic mutations that are present only in the affected brain tissue. So in epilepsy surgery, we are not that far developed as in all of neuro-oncology. However, we have approximately already 30% of all the common epileptogenic brain lesions that can be explained by genetic alterations. And just as an example, the ganglioglioma with the BRAF V600E and some other mutations, the FCD type 2A with the Gator pathologies, the FCD type 2B with the mTOR, or mTOR complex pathologies, the DNAD with the FGFR1s, for instance, MOGI, this oligodendroglial hyperplasia in epilepsy carry this galactose transporter mutation, SLC35A2, loss of function. And this list is increasing. So we probably can anticipate that maybe half or 60 or 70% of all these lesions are carrying specific genetic signatures. So it's important to understand how they work. And there are a certain interesting results that have been published over the last couple of years that I want to share with you, because I think it gives you a better background and a better understanding how to deal with these genetic lesions, and how to understand the disease better based on these findings. And as I said here, there are two things that you need to understand. First of all, that the genes can determine the size of the lesion in terms of when the progenitor cell was acquired the gene, and second, what kind of lesion it is. So in other words, in particular the FCDs and also these congenital brain tumors, they develop during brain development. They do not occur de novo after the child was born. The child already carried that lesion, and then it's just the postnatal development that determines when the first seizure occur and when the lesion really is truly visible. And shows signs, clinically measurable signs. And let's say this is a cortical lesion, because the epilepsy here or seizure is a very, very common symptom of a cortical lesion. Then we have probably 30 mitotic cycles, and the earlier the precursor cell is hit by the by the gene abnormality, by the loss of function or gain of function or chromosomal loss, the bigger the lesion is. Okay, so this is not to scale here, but it should just exemplify. The earlier the lesion, the earlier the gene is acquired, the bigger the brain lesion is, and the earlier the epilepsy is also showing off. You know, it's the presenting with seizure is usually the earlier the epilepsy occurs, the bigger the lesion is, the more gene variants you have, variant frequency you have. And this is the mTOR pathway, and combined with the MAP kinase pathway, which is more or less in the center of the FCDs and most of the congenital brain tumors. And so it's then the next point is not only the time point when the gene is acquired, but also which of these genes are acquired, because they all refer to different lesion types. And this is just as an example, the MAP kinase pathway genes almost always are determines LEAD. So the low-grade epilepsy-associated tumors, we call them LEAD, or congenital brain tumors. This is here the BRAF gene and other genes like the FGFR for the DNETs, and then you have a lot of other genes. RAS genes are well known, and so forth. And they are so when this affection here is introducing a BRAF mutation, then the lesion will become a brain tumor, in particular ganglioglioma. If this lesion is an mTOR gene or a DAPTC5 gene, it will be an FCD type 2 with these balloon cells here in particular. This is here the mTOR pathway, and then here this is the brain tumor. And this is not only the timing, but it's also the gene that is introduced that makes a difference. So the timing and the gene makes explains a lot of variability that we see. And then another thing that we just recently figured out, that this is also can explain also why the vast majority of these congenital brain tumors are in the temporal lobe, whereas the vast majority of focal cortical dysplasia are in the frontal lobe. You may wonder yourself, if you see these patients, this is quite consistent, and there are good explanations now why this happens. And one is here from our friends from Australia, Simon Harvey and group. They looked for the bottom of sulcus cortical dysplasia, which is a type 2 dysplasia. That is in their series, the vast majority is in the frontal lobe, and the mTOR expression in the frontal lobe is very low. So it's an mTOR variant that constitutively activate the mTOR signaling, which is usually not there in the normal brain. It should be not so much mTOR signaling in the frontal lobe. So this is probably how we understand why an mTOR mutation introduced in the frontal lobe cell lineage produces more likely an FCD type 2 than when it's in a region where you have already a very high expression of the mTOR signaling. That probably does not make extra noise, and that does not give these cells a separate advantage. And a similar finding is that for the MAP kinase pathway, where we know that the vast majority of these lesions are in the temporal lobe, and particularly the BRAF. And I looked up the BRAF expression from the Allen Brain Atlas on the internet, and you see here the same. Green is very low expression here in the temporal lobe on both sides, so lateral and mesial. So you have a low BRAF expression in the human brain, and then whenever you acquire like the BRAF mutation that constitutively activate the MAP kinase signaling, then this gives these lesions a significant advantage over the other cells. And I think this is also important to understand why these lesions are so predominantly localized in frontal versus temporal lobe. And that gave us also the evidence or the basis to include an integrative multi-layered approach for the classification scheme that just recently was published 2022 by the International League, where I showed you, the table before, where we had this type 1, type 2, type 3, MOGE, and so forth. But that is now only the layer 1. That is histopathology diagnosis, giving a description using appropriate immunostains, and then assign the histopathology finding of one of these classification diseases or subtypes as we have shown in table 1. And then in addition to that, you would benefit from having also genetic testing from that affected brain specimen. And whether you use the fresh frozen or the paraffin, whether you have peripheral blood sample as well, this is all what you may indicate. But that together, this integration gives you a much higher confidence of what the final diagnosis and your clinical diagnosis should be. And then we even included the neuroimaging. And the reason for that, and we can discuss this is if there's some time left, is that sometimes the histopathology does not receive the appropriate sample, that we cannot diagnose the disease on the surgical specimen because it has not been resected, has been destroyed by CUSA or other things, or just there was just a disconnection, and we could not receive the core lesion. However, with that, all these 3 layers, you come up with an integrated diagnosis that is based on the MRI signature, whether it's positive, negative, then whether you have the histopathology and the genetic finding. And then this is, I think this is state-of-the-art classification of diseases that gives you a good understanding of prognosis, of a prediction, whether or not therapy will be surgical therapy will be helpful, or if you have other additional alternative treatment strategies, in particular some drugs targeting specific genetic pathways. And here is a final example, MRI positive bottom of sulcus cortical dysplasia type 2B with brain somatic mTOR mutation. That would be, a very state-of-the-art diagnosis. And usually what you do when you do that in your post-surgical patient management conference, when you have collected all the different layers of diagnosis, bring them together and then have a final discussion whether they are all there, or they are congruent, or they are not overlapping. Then you have to decide as a clinician, as a treating physician, about the final diagnosis and taking all the level of confidence into account. Good. So that's basically what I just briefly mentioned, that we have now the opportunity for genotype-phenotype integration, and that will bring us to the next level of accuracy and therapeutic strategies, and also finally foster our research that we can much better stratify certain patient cohorts if they are defined not only by a very subjective histopathology report, but added value coming from genetic findings. Okay, so I will stop here just to advertise that the International League has this nice ILAE Academy learning platform where you can determine your learning path. This is not tutored. The layer one, they cover all the learning objectives necessary in epileptology, and go there, register, and look it up. It's quite interesting learning path, starting with level 1. It's all CME accredited, and then going to the proficiency level, and then even going to advanced proficiency, which is just recently opened up. So it's now fully functional, and hope to see you there. And these are the many co-workers of ours over the last years. And thank you so much for your attention.